Hi, this is Brian Kim. I'm going to share with you case number 244 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best way, but to get you to think critically of your technique, how you can refine and hone your technique so that you can provide the very best for your patient. So this is a tiny pupil with a dense cataract. In general, with small pupils, and you've seen my previous videos, I like to perform double chop and cross chop without using any pupil expanding devices. But with a tiny pupil and a dense cataract, when you have a dense cataract, you have a higher chance for zonulopathy. You have to use a lot more ultrasonic energy to disassemble the lens, and you don't want that iris getting in your way. So I do prefer placing pupil expanding devices, and my preferred technique is really to use iris hooks. And the pearl that I'm going to share is always placing a subincisional hook. And why is that? Because by placing a subincisional hook, you get that iris out of the way, and the chances of you eating the iris or having iris prolapse is much reduced with this technique. So I placed the corneal marker, which will help me to center and size the rhexis. Using the cotton tip to control the eye, I make my paracentesis incision first on the right side and then the left side. And I like the cotton tip because I can control the eye effectively. And now these are my incisions for the iris hooks. I place that first incision through the sclera. Again, I make sure I'm parallel to iris plane, but I'm in the sclera for sure. And that's going to be right where I place my main incision. And then these incisions on the right and the left side are for the iris hooks there. I'm placing 5 equidistant incisions, so I have a pentagon-shaped retraction with the iris hooks. And these are disposable iris hooks. These are one-time use hooks. And I like to just grab the stopper and position the hook into the incision. You can twirl your wrist in such a way that the hook points down. You can retract the edge of the pupil and then cinch down the stopper. So again, sliding it in, pulling the stopper back, pushing it down, twirling the stopper to get the hook pointed down, hooking it. There you go. I'm kind of lifting, angling, and now I was able to hook the edge and then cinching the stopper down. Many ways to use iris hooks. I use iris hooks all the time, so I feel very confident when I do it, and it really doesn't take me a lot of time using the iris hooks. Again, by just rotating your wrist, you can just kind of turn it down and then cinch it. Again, with iris hooks as opposed to a ring, with the ring, if the ring isn't right, then you have to take the whole thing out. With iris hooks, if you're not happy with one, you can just take it out, make a new incision, and then place it again. So it's really much more advantageous in challenging situations, not just for a small pupil cataract surgery, but when I'm doing like a dislocated lens and the pupil's small. A lot of dislocated lenses have small pupils because the small pupil does also reflect some zonulopathy as well. And so using iris hooks is really advantageous for a variety of reasons. There you go. So position it, roll my wrist, and now I have a pentagon-shaped retraction of the pupil. Pushing some intracameral epinephrine and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is the 2.4 millimeter incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea. And remember, I'm in front of the iris hook, so I'm not touching the iris hook at all with this maneuver. And these are the Moria micro rhexis forceps with the sharp tip ones. I'm able to puncture the center, pull down, grabbing the right side of the tear, and then going around circumferentially. I like to use the cannula to control the eye, and if I feel like the rhexis is trying to run out, I can push some more viscoelastic in. But it also acts as a way to control the eye so it doesn't turn in a way that makes it more challenging for me when I'm doing the rhexis. Again, the low profile rhexis forceps provides excellent control, minimal OVD egress. I don't feel in danger of the rexus radializing at all as I'm doing this case. Okay, finishing off the rexus. Burp some viscoelastic out. Coat the cornea with the viscoelastic. By coating the cornea, this allows me to have a clear view without having the technician to constantly having to place fluid on the cornea. It allows the technician to focus on other things during the surgery. This is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, get a nice wave, lift the lens up to help decompress the bag, push down on the lens, sweeping under the rexus edge on the left side, sweeping on the right side, and the lens begins to spin. By performing the capsule fornix hydrodissection technique, I never struggle with achieving the hydrodissection wave. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, keeping the bevel down as I always do, sliding the chopper under the rexus edge contra-incisionally. Again, I'm slightly pronating my hand, I'm leading with the tip, and I have it pointed down. I'm able to push down on the lens material. This ensures that I'm sliding under the rexus edge as I'm pushing the chopper out into the lens equator towards the periphery on the contralateral side. I rotate the phaco tip vertically, subincisionally. I'm embedding the phaco tip within the lens material. Since I have the chopper around the lens contra-incisionally, now I am effectively flanking the lens with the instruments. Now in this case, because it's a somewhat of a dense lens, the phaco tip, even though it's turned vertically, I'm really using it to immobilize the lens. It's like stabbing it like a shovel and holding it in position. I'm bringing the chopper and phaco tip towards each other. I'm able to fracture the lens. Again, because the phaco tip and the chopper are down and low, deeper at the same horizontal plane as the densest part of the lens, because I have it positioned deep, as I bring the instruments together, it fractures the lens very efficiently and effectively here. Go ahead and keep separating. I turn my wrist, sliding the chopper under the right heminucleus, sliding it by pronating my hand, and then straightening it out, and hooking the peripheral lens, making sure the chopper tip is around the peripheral lens. I have the phaco tip deep between the heminuclei. I pull the chopper centrally toward the phaco tip, and it fractures the right heminucleus in half. Lifting the first quadrant up with some vacuum, crushing the lens between the instruments, and then emulsifying the lens pieces. Very efficient and effective way to disassemble the lens into 3 pieces, utilizing double chop and cross chop techniques. Again, leveraging mechanical fracturing forces instead of using sculpting, instead of using lollipopping the lens and holding with vacuum. All of these maneuvers are really unnecessary if you know how to position the lens pieces to leverage mechanical fracturing forces. Turning the lens a little bit, getting around that second quadrant with the chopper, crushing the lens between the instruments, and then emulsifying the lens pieces. Turning the second heminucleus in front of me, placing the chopper around the lens periphery, flanking the peripheral lens, placing the phaco tip deep within the bag, crushing the lens in half with another cross-chop maneuver, placing the chopper around that third quadrant, performing the same maneuver once again. Again, because the instruments are deep, I'm able to effectively flank and chop and break up the densest part of the lens with each maneuver, and this is why it breaks so easily. And then just using some vacuum to grab the pieces, and then crushing the lens with mechanical fracturing forces, crushing the lens with the instruments, and then carefully pulsing with the ultrasonic energy to emulsify the lens pieces. Turning the last quadrant around, hooking the peripheral lens with the chopper, pulling it centrally toward the phaco tip, which is again deep, grabbing the lens piece with some vacuum, and then crushing it between the instruments, and then emulsifying the lens pieces. Once you get to this position, and you have most of the lens out. If the lens pieces are loose, that's no problem. You can utilize vacuum, that's no problem. But don't go fishing for lens pieces with vacuum in the peripheral bag or deep in the bag. Never go after lens pieces with vacuum or ultrasonic energy when you're within the bag. That's when you're going to break the posterior capsule. I only utilize vacuum to grab pieces when I know they're already loose and when they're not within the bag. And if it is still in the bag, I make sure there's still a lot of dense lens pieces that are protecting me from the posterior capsule. And now removing the epinuclear material. You can see it's rather thick epinuclear material protecting the posterior capsule as I finish that off. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start subincisionally, removing the epinucleus from anterior to posterior, peeling the epinucleus in such a way that it goes from the front to the back. And by doing it this way, you get a much cleaner removal of the cortex and less likely chances for those very fine, wispy cortical remnants. Switch to polish mode, polishing under the rexus edge. Polishing the posterior capsule. You can see the puckering of the posterior capsule when I grab it with the polymer tip. And again, I'm trying to make sure that the posterior capsule is nice and clean, but the puckering of the capsule does signify some level of zonular laxity. And as I said earlier, when I have dense lenses and small pupils, my default is always worrying about zonulopathy. And that's why I like to use pupil expanding devices in this context, because if the case becomes complex, if you have zonular loss or whatever, you don't want to have a small pupil in that situation. So you want to provide your best chance to get the best result with minimal complications. And so using a pupil expanding device with the dense lens and the potential for zonular weakness is really a good idea. So I'm using the sweeper to polish under the rexus edge on the left side and then the right side to remove any lens epithelial cells and any adherent cortical material. You can see the cornea is nice and clear. And I'm wiggling and wiggling, and this is the 3-piece lens, the MA60AC. This is a fairly tight incision, 2.8. Push some more viscoelastic in. You can see I'm turning the bevel towards the left. Pointed towards the left. The optic came out correctly. Using the cannula to push the optic in further and then dialing the trailing haptic into the bag. So in this case, I just used the viscoelastic cannula to do that maneuver there. And so instead of using the Multiman, I was able to use the cannula. Again, it doesn't really matter what you use as long as you use it correctly. I push the optic in and then dial it by pushing on the optic haptic junction. You can see how I'm easily able to take each of these iris hooks out, because again, I'm not going to be using these again. Once I disengage the stopper and disengage the pupil with the hook, I'm able to just yank it out. So go ahead and place the INA handpiece in without irrigation, activating irrigation, getting underneath the lens, removing the viscoelastic from within the bag. And remember, you have to do that maneuver with irrigation on. You can't do that with irrigation off. You want to be able to expand the bag before you go underneath the lens. You're making sure there's no viscoelastic within the bag, cleaning up any remnants as well. Just kind of rotating the lens a little bit here, trying to center it. Removing all the viscoelastic within the anterior chamber, and then I'll hydrate my incision. So again, this is a tiny pupil with a dense cataract. Again, for me, code word for tiny pupil dense cataract is potential for zonulopathy. And because you're dealing with a dense cataract, you're going to have to use a lot more ultrasonic energy And because you're using a lot more ultrasonic energy, you don't want the pupil near the phacotip. You might eat the iris. You might do something you didn't really want to do. And it's really unnecessary to struggle. And so using a pupil expanding device makes a lot of sense. I prefer iris hooks. And my biggest pearl is, instead of using 4 hooks, use 5 hooks. Use that first hook in the subincisional area, i.e. you're going to stab the sclera, making sure you're nice and parallel to iris plane. So that means you're going to definitely be above iris plane, and you're able to slide that hook in. Before you do that, you go ahead and make your main incision. And now, because you have that subincisional iris hook, you're not going to have any iris prolapse. You're not going to have any iris trauma, because you're not going to be able to eat the iris because it's retracted. To me, this is the most efficient, most common sense way to use iris hooks in this setting. And again, I prefer iris hooks because they're more versatile in this situation. And so this is, again, a case showing a tiny pupil dense cataract using the 5 iris hook technique with the subincisional iris hook. So I hope this was helpful to you, and I thank you for your attention.